Uh, Very good morning to all. This is Dr. Adarsh E, Professor at Department of Paediatrics. Welcome to the today's theory class, and I hope you all are keeping safe yourself and keep a distance and take care of yourselves. So today is very important topic in the pediatrics is it's related to the kidney disease. This is one of the these are the commonest kidney disease what we are going to see in our day-to-day practice. Other disease related to the kidneys are acute glomerulonephritis, nephrotic syndrome, urinary tract infections. These are the commonest. Usually, we are going to discuss in our pediatric area. So let us start with nephrotic syndrome. See, nephrotic syndrome, the old terminology was chronic nephritis. So, I'm going to tell you today what are the outline we are going to discuss about nephrotic syndrome. So, what are the learning object today you are going to learn? First, we will let us see about outline of pathophysiology of nephrotic syndrome. Then regarding the definition of nephrotic syndrome, then we will go to classification etiology of the nephrotic syndrome. Finally, we'll briefly and we are going to explain regarding the clinical features. What are the clinical features you are going to see in a nephrotic syndrome baby, and what are the then as you know that acute glomerulonephritis and nephrotic syndrome differentiation we had to do. Then finally, how to establish this is a nephrotic syndrome. So that is the one laboratory. So we have to go with how to plan, how to investigate a child presented to with you nephrotic syndrome. Later, finally, once you diagnose, confirmation diagnosis, then you should plan for treatment and finally follow up because it is long-standing disease. It lasts for almost 2 to 3 months. If a typical nephrotic syndrome comes and it will disappear. If there are relapses are there, then it will go runs for longer time. Then finally, complications of nephrotic syndrome per se and as well as the drugs whatever we're going to use. So then first we'll start with definition of nephrotic syndrome. Nephrotic syndrome is defined as an renal glomerular disease disorder which is characterized by massive proteinuria, means the protein will be losing protein. So the massive proteinuria means there should be minimum of, if you measure the loss of protein in the urine for 24 hours, if it is more than 3.5 gram, then it is called as there is massive proteinuria. Hypoalbuminemia means whenever the protein is lost from the body, definitely the body level of albumin is going to decrease. So usually the albumin level will be drops as below 2.5 gram per deciliter. Hypercholesteremia. So these are interrelated. Once the hypoalbumin protein will be there, the cholesterol level will rises more than 200 milligram per deciliter. With this, he should be having an edema. See, this child will be having progressive edema. In contrast, in acute glomerulonephritis, AGN cases, you'll get sudden onset of edema. So let us, so you understood the definition of nephrotic syndrome. Say massive proteinuria, hypoalbuminemia, hypocholesteremia. These are the features. These are things should be there in the definition of nephrotic syndrome. So let us will understand what is pathophysiology. See, you are seeing here. This is a complete glomerulus. This is a nephron. As you know, nephron is one of the it is a functional unit of kidney. So this is the one is going to decide the condition of the kidney. So this is whole nephron. As I said, it will be there in the kidney. This let us discuss about this glomerulus. So this glomerulus will be, once you do a cross-sectional things, it contains the blood vessels, afferent and efferents. Okay. So these will be get filtered in this Bowman's capsules. So this is very important for us is what all the things are going to happen in the Bowman capsules. This is normally Bowman capsule will be intact. Understood? Such cases, this ultrafiltrate get filtered, the urine will be the waste product will be separated from the blood. So this function is prime function of a kidney. So let us see So this is this microscopic version of Bowman's capsule. So you can see here. See here, there is a gap. This gap you are going to see in this conditions. Okay. So as you see here, these are capillary lumen. What we are saying, this lumen, no, this is a capillary lumen here. So whenever that comes, it starts filtering here. These are endothelial cells. These are lined here. It has to be drained with the Bowman's capsules. So it will be intact in normal cases of all of us. It will be intact. So in the conditions of nephrotic syndrome, it will be not intact. So one more figure of regarding the nephrotic syndrome pathophysiology. See here, still further, you can see here, this is a kidney. So this is the area how the glomerular filtration takes place here. Is a nephron and glomerulus. Okay. So here the podocyte cells they have a lot of role in filtering of this capillary from the capillaries. So here this glomerular filtration, this basement membrane should be intact. If the intact-utility will be lost, then the podocyte cell body will become abnormal. Then there will be a minute leakage of the your albumin from the blood into the urine. You are going to see. What are the pathogens usually? It is immunomediated. I'll tell you later what it is. Systemic circulating factors also responsible for to the damage of this basement membrane. Okay, podocyte related factors. ANGTPLA4. These are factors are responsible for giving the gapage in the Bowman's capsule. I mean basement membrane. So some of them there are some genetic variations are there. So these are the commonest pathogenesis what we are considering. So what is going to happen? What is abnormality is going to take place? So here the increased permeability of the glomerular capillary wall will be there, which leads into massive proteinuria that is going to lead into hypoalbuminemia. Once the permeability increases for albumin, that time the protein will be lost in the urine. And what is the role of podocyte? I already told this podocyte is the one plays a crucial role in the development of proteinuria, means the protein will be lost in the urine, and which is going to cause later the glomerulosclerosis gradually as it progresses. So the food processes I have shown previously, food processes. These are the food processes. Okay, so these food processes are also contains the podocytes inside. Integrate designate with the adjacent podocytes and connected by the slit called as slit diagram, means the gaping will be takes place. For all these things is the podocyte CD284 and alpha antinin 4 are responsible for this permeability to the albumin we are going to see. So in all forms of nephrotic syndrome, the immune and non-immune insults are due to podocytes that leads to food process damage we are going to see. Because of this, the decrease in number of unfunctional podocytes. So podocytes will become unfunctioned. So later that is going to be going to give rise to end results will be increased leakage of the protein from the Bowman's capsules, basement membrane. So here is a classically, very briefly, this please remember this you have to put in the theory whenever the questions will be asked. So this diagram you should know. So here is a slit diagram as we already discussed. These are food processes. Once again I am repeating this, and these are the capillary lumen here. Okay, this endothelial cells are there. This is a basement membrane. This is the one where the slitting will occur. Because of this slitting, because of the negative charge which is present, it will be lost here. So because of negative charges lost, the albumin will be giving the seepage into the urine. Okay, so that's called albuminuria. So as once again, as I said already, the glomerular basement membrane will be negative charged normally, negatively charged. Why this negative charge is going to help us to prevent a seepage of albumin into the urine. Okay, secretates from the capillary to the urine. Okay, So because of the negative charge it loses, the loss of negative charge leads into inability to respire, means it cannot prevent the leakage of the protein. So the leakage starts because the proteins are negatively charged, albumins are negative charged. So because of this, as it goes, the disease progresses, there will be increased loss of albumin. If it is decreases, if it is more than 3.5 gram per 24 hours is lost, that is nephrotic syndrome. So, as a brief, these are damage is not because of any of the organisms, any of microbia. These are defective cell-mediated immunity in that particular child. Number one, the immunity status will be defective. The T cell mediated immunity is less, and also it will be further. It is helped by interleukins IL-2, IL-1, IL-6. These also will be contributing by the circulatory factors. Those are present in the blood. They are also going to help to causes the immunological damage to the basement membrane. So let us discuss about incidence. It is about 1 to 3 new cases every yearly we are going to see in a child as less than 7 years old children or 1 lakh children. So let us discuss etiology. See, there are the etiology you can classify into primary idiopathic nephrotic syndrome and secondary nephrotic syndrome. So let us discuss primary idiopathic syndrome. In primary, about 90% of them they are idiopathic nephrotic syndrome. The cause will be not be known, unknown cause. So the other different types of primary idiopathic nephrotic syndromes are depending on the damage to the basement membrane. We are going to classify into minimal change nephrotic syndrome. About 80% we are going to see in under 6-year-old children, around 20% more than 7 years old children. So usually the minimal change nephrotic syndrome is seen in the less than 6-year-old children. So this disease of nephrotic syndrome seen in less than 6 years old children. Please keep in your mind. Focal segmental, this is one more type of glomerulonephritis. Glomerulosclerosis, then membranoproliferative glomerulonephritis, membranous glomerulonephritis, and finally congenital nephrotic syndrome. In children, we will see a congenital nephrotic syndrome. This is commonly seen Drash type of nephrotic syndrome. It is involved. This is a genetic in origin. It will see sometimes as early as about 6 months old children. You can see congenital nephrotic syndromes. So let us discuss what are the secondary causes. There are so many secondary causes are there. Briefly, I will tell 1 or 2 in that. Coming to the connective tissue disorders, in this systemic lupus erythematosus is one of the commonest nephrotic, causing nephrotic syndrome in the secondary causes, and HS Henoxius purpura. This is also what we'll see in the Henoxius purpura. Usually, you have nephritis. It will joint involvement as well as purpura. That is, blood will be involved. So some of the infections also lead into nephrotic syndrome. What are the infections? Hepatitis B and C both, malaria and miscellaneous others are drug-induced malignancies, and sometimes the bee sting. There's a bee stings. This is also going to cause antigen-antibody reactions. They are going to damage the basement membrane in the glomeruli. So let us go to clinical features. Clinical features, as I already told, it is seen in the less than 6-year-old child. It is very important. So it has to be seen only less than 6 years. If you are going to diagnose more than 6-year-old children nephrotic syndrome, usually it will be wrong. So always, please you think of the nephrotic syndrome means less than 6-year-old children, 6 years to 6 months. Please keep your mind memorize. Usually seen more in males rather than females. It is 2:1. It is progressive onset, that is insidious onset. Gradually, the edema comes the face first, then gradually it decrease. It comes to the abdomen, then it comes to the trunk, as well as sometimes in males scrotum and as well as lower limb edema. So progressive increase in the edema. Okay, so you should remember the triads. These 3 triads you have to tell whenever nephrotic syndrome is there. Number 1 is progressive edema of the body. If the child complains of progressive edema. Number 2, hypoalbuminemia means the blood level of the albumin level is decreased less than 2.5 per deciliter. And there will be cholesterol level will be shooting up. It has to shoot it more than 200 milligrams per deciliter. And finally, as the edema progresses, the patients, they can see there is decreased output of the urine. That is usually we'll use the terminology as oliguria. So let us discuss about the edema. Most common presentation, what we'll see in our pediatric practices, okay? And there are two hypotheses are there. One hypothesis is underfill and overfill, means whenever in one small vessel will fills less, that is also going to cause us nephrotic syndrome. Overfill also going to cause the nephrotic syndrome. Let us see what is this underfill and overfill theory. So this is about underfill theory. What is going to happen in the underfill theory is here increase glomerular permeability to the albumin. As I already said, because of the immunity, I mean less immunity and as well as immunological causes, there will be a leakage of the albumin into the urine. This results into albuminuria, means urine contents of albumin is called albuminuria. It is lost. So once the albumin lost in the urine, that results into decrease in the albumin level in the blood. So it is going to decrease by 2.5 grams uh, per deciliter. It is blood level of the albumin. So later, once albumin decreases, what is going to happen to the oncotic pressures? As you know, if the albumin level decreases in the vessels, the oncotic pressure in the plasma will be decreased. So which leads into, it is a physics, simple physics, which leads into the effusion, means movement of the water from the intravascular space, means from the vessels into the interstitial spaces. So because of interstitial spaces, it is fluid comes. So once the fluid lost from intravascular spaces to interstitial space, the volume in the vessel intravascular space will become hypovolemic. Understood? Once it becomes hypovolemic, there will be non-somatic ADH release will be there. So once the ADHD hormone releases, that is going to shoot up for then one it's going to I'll discuss later. So, okay. Similarly, hypovolemia will be there. They will become symptomatic nervous system symptoms you're going to see. So because of hypovolemia increase the ADH level and as well as CNS symptoms you are going to see. Okay. Then once the hypovolemia comes down, the angiotensin and renin activities which is present in the kidney will be increases. In result, because of that, the renal water and sodium retentions we are going to see. Because of retention, that is once again it is going to trigger back to decrease the oncotic pressure in the intravascular space. So this is a pathophysiology of one of the theory. What I explained is underfill theory. Let us go next about overfilling theory. In this overfilling theory is nothing but the primary renal sodium retention. So here what is going to happen? Usually there will be exchange of sodium will be there in the glomeruli. But because of the disease, the renal sodium will be retained. The sodium will retain in the body. Because of increased sodium retention, it is going to increase the blood volume. And as well as because of blood volume increases, the increased blood pressure will shoots up. So because of the blood pressure shoots up, you are going to see altered features of the local tissue levels. Because of that, the fluid will become such stays in the interstitial spaces. Okay. So as I said, because of volume and as well as is going to increase the suppression of renin and angiotensin system. So this is going to cause, this is edema. See, this is a beautiful picture of the baby. You can see this is a periorbital edema. All the creases, it will be lost and it looks like almost puffy face. So gradually, this is early stage of periorbital, early stage of edema. Gradually, I already told you, it is going to become, whole body is going to, you see the collection of fluid here. So here in a male children, you can see there is scrotal edema. If the child, these are dependent areas. So you can see here the thigh also looks like edematous, and even scrotal edema is also there. So this is nothing. This is a feature of ascites. So you can see here this whole abdomen is full here. Okay, tensed up. Okay, and this is a even lower limb also. You can see this edema here, the penile scrotal edema. These are edemas. What you'll see as the disease progresses. So this is a beautiful picture it is showing you. If you go to press a medial aspect of the just above the malleolus, you will see there is a pitting edema. You can see. So here you can see this is a pitting edema here. So this is one more feature of massive ascites. So this is occupying whole of the abdomen. You can see here a stretching of abdomen. I mean umbilicus. You can see many vessels are dilated here. Okay. You can see here. You can trace here. So these vessels are dilated. See, so we don't know. Sometimes ascites also going to take place in the cases of superior vesical obstruction as well as sometimes inferior vesical infections. So edema once again repetitions. Scrotal edema I already shown you. So sometimes as the disease progresses, in addition to ascites, you can see collection of the fluid into the pleural cavity. So what are the clinical features or depends on all these things. So let me decide one by one. I will see hyperlipidemia. This hyperlipidemia is decreased because of decrease the catabolism and as well as increase the synthesis of the albumin here. Okay. So because of that, the lipid level is going to be increased. Similarly, such children are going to be susceptible to the infections because the immune system will be lost and the complement factors also be lost. Usually complement system, we are going to see complement 5 and it will usually decrease. They are especially prone for infections, mainly due to cocci. That's the capsulated organism. Cocci, Staphylococci, these are organisms usually they causes infection in such children. There is finally sometimes we'll see cellulitis, sometimes we'll see infection of the peritoneum also that leads into peritonitis. Finally, some children they suffer of bacteremia and sepsis. Usually, very rarely we'll see such in the children because it is a immunocompromised status. What we'll see in nephrotic syndrome. So, in addition to that, we'll see because of the hypercoagulability. This is also one more thing. We'll see the signs. What we'll see symptoms of signs we'll see because of hypercoagulability. Because of the concentration of the intravascular system will be increases, so increased platelet number, which is causes aggregation, loss of antithrombin 3 and protein S. These lead into such children will have hypercoagulability. Means because of coagulability they will have thrombosis, can go and cause CNS system can occupy. So you will see some of the thrombosis going to block the blood supply to the central nervous system, results into hemiplegia. Let us see that I will discuss later. So let us differentiate what is nephrotic syndrome, what is acute glomerulonephritis. I think you already discussed as acute nephrotic syndrome has been discussed to you. So first let us see what is nephrotic syndrome. See, in compared to acute glomerulonephritis, this is an infective, this is immunomediated. Okay, this is a post-streptococcal infection, acute glomerulonephritis. This is, as I said, acute in onset. Here, insidious, progressive in onset. Edema will be there. This is a progressive edema. Here, rather than edema, they present hematuria, oliguria. Sometimes, initially, he'll have oliguria also. Okay, this presentation itself is oligurial acute glomerulonephritis. In contrast, oligurial state comes in the later stages of the nephrotic syndrome. Okay, edema also will be there later here. So edema appears first here, edema appears later. Oliguria comes first here, oliguria comes second. Please keep in mind. Here hypovolemic shock. In contrast, you will have hypertension. Some of the cases you will see even hypertension also. Very few cases, or 20% of cases. Here you will see ascites because of collection of fluid in the ascitic peritoneal area and as well as the pleural area results into pleural effusion. But in contrast, because of abnormal electrolyte imbalances, it will there throw seizures and finally they are present with congestive cardiac failure also. So please memorize these 6 points in your mind. Whenever a nephrotic syndrome comes, we are going to ask you about acute glomerulonephritis. Please remember, because this nephrotic syndrome as an acute glomerulonephritis, as long as theory, this is even practical also, we are going to keep this for our case discussions. So some of them, as I told, they are typical. Some of them are atypical. As you can see previous slide, The hypertension is not going to see nephrotic syndrome, that's what. But some of the atypical cases, you will see hypertension, sometimes gross hematuria also, steroid resistant cases, hypocomplement means as I already said, complement system will be inactive. So joint involvement, sometimes you get skin rashes, final stage they go into renal failure. So once you diagnose, once after seeing the clinically, you should establish what it is. For that, we should go for laboratory investigations. What are laboratory investigations you should do? One is regular hematology you have to do. Hemoglobin. The hemoglobin appears to be decreased. This is all because of dilutional anemia. Okay. Sometimes you have to rule out by doing the peripheral smear. If there is anemia is due to some other causes, you have to rule out what the cause for anemia. Okay, you should do WBC count to know, rule out whether there is an infection is there. See, whenever there is infection is there, the WBC count will be rises up to 20,000, more than 20,000. So once again, we'll do differential count in that. Neutrophil counts will be increased in case of infections. So let us see what is going to happen in the urine. So we have to do the urine test for presence of protein in the urine. Usually the protein will be detected in the urine in the cases you are going to see here. There is a massive protein will be there. So by doing the proteinuria, that indicates protein will be there. That's the best test. Sometimes you can do even some other test also there. So you can use sulfuric acid also to see the protein. Now previously what we used to do, it is heat coagulation test also. So these all are, we have to grade 1, 2, 3, 4 proteinuria presence in the urine. So we have to test as a routine sugar for to rule out any diabetes is there. We should do microscopy, culture and sensitivities to see whether they have got any infection is there or not. So you have to detect lipiduria is there, presence of lipids in the urine. Detect the urinary tract infection because you have to rule out infections before going into the treatment of the nephrotic syndrome. So as we already told, biochemistry investigation, blood urea, you should see blood urea will be raised. Serum creatines, you have to check. Usually in acute glomerulonephritis, it will rise here, it will borderline electrolytes. Usually it will be normal, but contrast, cholesterol will be very much high in the nephrotic syndrome. So urine protein test, as I already told, there are so many tests are there. You can see here that is the denaturation, that is PPT will be found. By using the sulfosalic acid, if you take around 5 ml of water, urine, into the test tube, along the side, gradually one drop per time, if you go on putting the sulfosalic acid, gradually it is going to cause denaturations, which results into precipitation of the protein which is present in the urine. That indicates it is proteinuria, the protein is present. Sometimes you will get false positive things, probably might because of contrast agents, high levels of antibodies present in the urine. But this is a very beautiful test, this side lab test, what we are going to do in our WhatsApp. So nowadays the dipsticks are also available to detect what is the total albumin lost in the urine based on the thing. Taken albumin and dipsticks has to be taken. If you put a dipstick, if you see yellow with this color, it indicates there is a negative for albumin. If you see this light green color, parrot green color, it shows there is the 2+. There is traces that means 15 to 30 milligram per deciliter. Usually, normally, urine doesn't contain albumin. Okay, and if it is, as I already told, 1+ is nephrotic. If there is a 1+, 30 to 100 milligrams per deciliter will be there. If there is a 2+, 100 to 300 milligrams per deciliter, and 3+, it will be 300 to 1000 milligrams per deciliter. If we say 4+, with the precipitation, you are going to see this color means it is more than 500 milligram per deciliter. So these are the commonest dipsticks. This also nowadays all this will be given to the patient. They can test at their home also. Okay, this is a very easy method. Within few minutes, you will get this test. So these are lipid bodies which are collected in the urine. We can see under microscopy. And one more is you'll see. Even in microscopically, you will see present of Holland bodies. Urine, investigation specific. In the urine, you have to do 24 hours urine protein levels because as I already told, the urine protein level, 24 hours urine level is more than 3.5 gram for 24 hours. That is positive for nephrotic syndrome. This is a This test usually regularly we'll do in our regular test. Okay, I mean what we'll do in our side labs. And this is the one always all nephrotic syndrome. This is the one we can do diagnostic to say this is nephrotic syndrome. So as I already told, presence of urine in the urine, protein in the urine, protein and creatinine ratio is very important. If the protein and creatinine ratio is reversible, more than 2, then that is also goes in favor of nephrotic syndrome. Okay, so this comes proteinuria, protein and creatinine ratio is more than 2, that is also comes we can say that this is nephrotic. So you should remember in a nephrotic syndrome, these are special investigations. These are more specific. 24 hours urine protein presence in the urine more than 1 gram per square meter area for 24 hours or 3.5 gram per 24 hours. Protein creatinine ratio is more than 2. Serum complement ratio it will be normal and it will decrease in nephrotic syndrome. HbA1c test has to be done because to rule out secondary causes of nephrotic syndrome. These two are done in atypical case of nephrotic syndromes. Certain investigations you should do because you should do Montauk's test to rule out tuberculosis because it is going to, before starting the treatment of the nephrotic syndrome babies, as I already told, it's immunocompromised status. That's what we are going to do a Montauk's test in all children to rule out. So we'll do routine chest X-ray. We'll do prerequisites for urine, as I already start before starting cardiac study. We should do. And certain atypical nephrotic syndromes and congenital nephrotic syndrome in children less than 6 months old baby, if you see, and some of the case of steroid resistance means if you start steroid even after 2 to 3 months also, it doesn't respond. Nephrotic in such cases, renal biopsy is also indicated. If the atypical means hypertension, persistent hypertensions, increase potassium level in the body, and as well as massive proteinuria persistent in cases of nephrotic syndrome, you will go for renal biopsy, indication of renal biopsy. So, how to differentiate laboratory-wise AGN from nephrotic syndrome? Urine protein massive here, 3 or 4 plus here, 1 or 2 plus. Urine lipid bodies will be present, but here RBCs will be. Means here WBC cast is RBC cast you are going to see. Please keep in mind. This is RBC cast, this is WBC cast you are going to see here, and you will see urine lipid bodies. This is a diagnostic feature of nephrotic syndrome. 24 of urine more than 1 gram per body surface areas. Here RBC cast you are going to see as already told. Okay. And then urine creatinine level is more than 2. Here azotemia. Okay. Here serum albumin less than 2.5 gram. Hyperkalemia. You will see hyperkalemia. Some atypical cases here also see, but hyperkalemia means is AGM. Okay. Serum cholesterol level more than 250 gram per deciliter. Okay. These are the differentiation laboratory wise. We already discussed previously. Clinically now laboratory wise we can differentiate this. So to diagnose finally, once you take detailed history, clinical features, after understanding the pathophysiology, after doing the investigations, you should have this triad to say nephrotic syndrome. Please remember, okay, the edema is the first thing. The edema is common. Without edema, you cannot diagnose nephrotic syndrome. In addition to edema, there is proteinuria should be there, hypoalbuminemia should be there, hypocholesterolemia. That's what in the definition itself. With the proteinuria, hypoalbuminemia, hypocholesterolemia, with the presence of edema is nephrotic syndrome. Please remember this diagram. You have to put this diagram in examination. It is self-explanation to the examiner. I think you will learn good marks in this. Let us, once you diagnose, how to treat the nephrotic syndrome. The treatment we have to plan. What are the first steps you should do? We should confirm diagnosis. First, to treat any disease, any treatment to give any disease, you should confirm diagnosis. Once you confirm that it is a typical case of nephrotic syndrome, then you should confirm whether it is a typical or atypical. You should rule out infections. That's what I said in the investigations. By doing the WC counts, by doing urine culture, by doing the urine routine, you can rule out there is any infections. You should rule tuberculosis. That's what chest X-ray and as well as Montauk's test you should take and rule out tuberculosis. then you should see any complications are there or not. And finally, you should educate the parents. If the child is little older, you can understand it, you can give education to child also. So this is the first steps you should know. So finally, we'll coming to the main treatment. So this is general. How to general? See, you should give supportive treatment to the child. Edema management. Then
ಅವನ್ಗೆ ಹೇಳಿದ್ದೆ
you should edema management, supportive treatment, complications of management. You should do vaccination. The finally, the corticosteroid treatment is a specific one. So this is about, let us see about the supportive treatment. So diet, the diet compact is very important in this case. The diet should be, the protein requirement will be 1.5 to 2 gram per kg per protein. Protein should be there in the diet. You should provide the normal calorie to the child. The fat is not more than 30% of the calories, what the normal calorie what you're going to get. You should do salt restriction if the edema is very much more, or if there is a BP. Hello. So corticosteroids, please unmute. Please mute yourself. Hello. And corticosteroids. If there is edema is there, you should use corticosteroids. Water immersions therapy, diuretic infusion, and albumin therapy also. So then this is the one you should use to prevent infection, because the nephrotic syndrome babies will be having immunocompromised children. Such cases, you should not give live vaccines. Give pneumococcal and H influenza vaccines. As I said, pneumococci, as I told you, cocci will be going to infect such children very much more. First, then we'll plan. This is a classical treatment of nephrotic syndrome. For example, if the child comes with first episode of nephrotic syndrome with the absence of hypertension, please note it down. There should not be hypertension, hematuria, azotemia. Such cases, we are going to start with prednisolone. 2 milligram per kg per day daily for 6 weeks continuously. We are going to give. Once there is a remission occurs, remission means the urine is free of albumin for consecutively 3 days. So then you should go on tapering of the steroids, prednisolone. It is once you are beginning 2 milligrams, once 6 weeks over, the remission in the remission period you should change over to 1.5 milligram per kg body weight on alternative days. For total for 6 weeks, gradually you should go on tapering. So this is commonest cases of a single first episode of nephrotic syndrome. If there is relapse occur, for example, if I go to treat this child already, such cases the relapses are going to occur. Such cases will do that is called infrequent relapses. If infrequent relapses comes, once again we restart the prednisone 2 milligram per kg body weight until remission occurs. Once remissions means once the protein persistently 3 days, the urine free of albumin, such cases will go back to 1.5 milligrams per kg body weight on alternate days for 4 more weeks. So sometimes frequent relapses. Some children, after treating with the primary nephrotic syndrome, they'll get frequent relapses. We are going to see such cases. They are period dependents. Okay. So such cases we will refer to the for evaluation alternative day prednisolone. Such cases we'll start with once baby comes very frequently. Such cases alternatively we'll start with prednisolone. Maintain the remission. The aim is to maintain the remission status. Remission means the urine should be free of albumin. Okay. The assess the steroid threshold levels. This is very important. We have to maintain threshold level regularly. Once the threshold level is less than 0.5 to 0.7 milligram on alternate days prednisolone for 9 to 8 months, you should give almost 1.5 years such cases. If threshold is more than 0.2 to 0.7, such cases you have to change over to other alternative treatments. This is a beautiful flow charts, please you should remember. Okay, then such cases threshold is very much more. You should switch out levozole. There's a immune modulating drug. Cyclophosphamide drug can be used. Tacrolimus and mycophospholates. Then cyclosporins. These are immune modulators. Drugs can be used. Cases of frequent relapses. Sometimes there's steroid resistance. In spite of giving this treatment, such children they never show a response to the steroids. Those cases are referred as steroid resistant. He referred for further evaluations has to be done. So we have to shift it for renal biopsy. Please remember this. This flow chart is very important. This tells you whole treatment of nephrotic syndrome, infrequent relapses, frequent relapses, and steroid resistance settings. So this I already explained now. So already told in the diagram. Okay. So let me tell once again here. If the corticosteroid relapses, steroid 60 milligram per body surface area. So for 24 hours or 2 milligram per kg body 24 hours. Already told. So remission means free of albumin. Once remission occurs, should switch on to 1.5 alternate days. Gradually should taper by 4 weeks. Should be given once a day. Okay. So once you treated steroids, the complications, we should discuss about complications. See, this complication might be steroid itself or the disease per se or because of other problems of the disease itself. So what are the complications? See, sometimes you'll have massive edema. Sometimes you'll have protein energy malnutrition. Because the immunocompromised status, such children will be there, they'll be having frequent peritonitis, infections of the body tissue, leads to cellulitis, frequent respiratory tract infections, leads into pneumonias, urinary tract infection, thromboembolism phenomena. I told because of hypercoagulable status, which is present in the blood that leads to emboli, they produce emboli and causes central nervous system emboli and causes there is CNS, hemiplegia, hemiparesis, hypotension, which leads into shock also. You should be very cautious. Depending on the factors, you should go on treating the complication. Sometimes hypothyroidism also will be having, you should treat the hypothyroid levels has been done regularly, and based on the thyroid level, you should treat the thyroid disorder. Okay, and iron deficiency, iron should be corrected. Anemia should be corrected. You should supplement with the vitamin D deficiency. This leads into should take a vitamin D because of this iron deficiency and vitamin D and as well as protein malnutrition. The child is going to have growth failure. So as I said, drug itself, drug overdose, they'll present with Cushing features, moon face, and baby put on weight. The humping we are going to see on the shoulder humping. These are the Cushingoid features, what you're going to see in hirsutism, loss of hairs, lot of hairs grows on the face, you can see also. Okay, so baby is going to start gaining the weight. This is because of drug per se. The treatment, what you're going to do, that should be monitored well during the course of treatment. So this is peritonitis, the features, what you'll see. You can see this early feature of cellulitis. Okay. And you should do if there is infection, to rule out peritonitis infection, you should do drainage also. If there is a more than 250 cubic cells per cubic millimeters, or out of them all are more than 50% neutrophils are there, that gives a clue that there is peritoneal cavities got infected. You should send for gram stain if there is presence to rule out any presence of any organisms, and based on culture you should change over the antibiotics. The asymmetry of the lower lips in the deep vein thrombosis, I already told. This deep vein thrombosis is going to occur in certain cases because of hypercoagulatory status of the baby. This is a cerebrovascular accident, I told now. So once the baby have the thrombosis goes and lodges into the brain, it is going to cause sometimes monoparesis. You can see only one limb paresis, some hemiplegia you can also see, depending on where this vascular occlusion going to take place. So you have to do the prolonged capillary filling rate will be very much prolonged. That indicates that the baby is in shock. Short stature, pushing at feature, I already told this is a drug induced cases. Okay, because we'll give steroids for more than 2 months. Such cases you'll see you have to watch these features. You can see face is almost chubby cheek, like you can see there's some hair growth is there. You can see there's a obesity, like you can see these all are because of this is post Cushinged features because of steroid therapy. So as I told, once you rule out if there is infections or chances, please do the start with basic antibiotic and under the coverage of antibiotic and reduce the steroids level. If there is hypoalemia there, you can give albumin infusion also to increase the volume level in the in the baby, and in turn you can reduce hypovolemic shock. Okay, to prevent hypovolemic shock, you have to give albumin can be infused. Very carefully, fluid should be infused. For thrombosis, because of, as I told, if you find out any early signs of hypercoagulability, in such case, if PC level is rises more than 55 with symptomatic, such cases you should use anticoagulant therapy should be used as an adjuvant treatment. So final thing is you should do urine examinations. Parental counseling should be done. Very important. Please tell them how to do urine examination of the child. The regular urine examination should be done at home by using the dipstick. I already told. Sulfuric acid is very little bit difficult. Boiling test is all different. So nowadays the dipsticks are available in the pharmacy. You can show them how to use, and it is already color coding. You can interpret it and write on the one paper, and while coming to examination or follow-up, you should show us. Daily urine examination in the morning during a relapse. When there is a relapse is there, you should do daily. Okay. During intermittent intercurrent infections, if the infection also, you should do daily thing. Okay. If the child notices puffiness in the morning, then also urine examination they should do. Based on the urine report, you should come and show it to the consultant who has seen previously. Frequent urine examination is reduced, and beginning we should do frequently, gradually reduce twice a week, and during the remission period only. If the remission means if the child doesn't have albumin persists for three times, then it is not required. So next every week we should do once a week. Beginning we should reduce it twice, then go for once a week, then finally you can stop it. So regular checkup is required because there is a frequent relapses, steroid dependency you are going to see. So their dairy has to be maintained. They have to maintain the dairy. What medication the child received, what are the child urine protein has to be noted down in one small paper or a diary. Okay, and the presence of any infection signs are there, symptoms are there, that also should be noted. We have to instruct the parents that not to restrict their activities. They can go for normal activities, and they can go to school. They can attend school. There are no any restrictions for children. They can attend the day-to-day activities. And regular, the age-wise appropriate immunization should be advised. They have to take regular vaccinations, whatever is required for the particular age. And extra infections to prevent streptococcal infection, pneumococcal vaccines, meningococcal vaccines, if they can affordable, can be advised. So this is about parental guide. So our follow-up, how to do follow-up? If the follow-up is only comes if there is relapse or remission. If relapse means defined as the urine albumin more than 2+ in an early period, in a morning sample for 3 consecutive days. Please remember, this question will ask what relapse means. If the albumin level 2+ for 3 consecutive days in the morning, that's called a relapse. What is remission? Remission is urine albumin nil or traces for 3 consecutive days. This is normal. Okay. Please remember, these questions are frequently asked in examination. How to follow up case of steroid-sensitive nephrotic syndrome? In the remission, even after stoppage of the steroids. Steroid-dependent nephrotic syndrome relapse during tapering off within 14 days or stopping steroids. Steroid-resistant cases, nephrotic syndrome, no remission even after 4 weeks. Then you should increase the dose of the steroids. Other drugs, please note it down. These you should remember. Cyclophosphamide is this is commonly used anti-malignant drugs, cancerous drug. Prombicil also it is a drug used because these have got lot of side effects, but it is a final cases. If that doesn't respond to even steroid, also we have to change over to these. This is immunomodulator. The cyclosporine also immunomodulator, and this is a new drug, tacrolimus. This is the drug used nowadays over nephrotic syndrome treatment. So a few words about the congenital nephrotic syndrome. You will get the short notes. Congenital nephrotic syndrome defined as a syndrome manifesting at birth, that is less than 6 months old children. That is classified into primary and secondaries. Primary because of genetic in nature, because of presence of in the nephrin, and as well as podocyl. As already told, the main basic it is present in the basement areas. Okay, so the absence of NPHS1, NPHS2, and LAMBE2 genes. Sometimes, intrauterine infections, cytomegalovirus, toxoplasmosis, syphilis, hepatitis B, HIV, infantile SLE, these can give rise to congenital nephrotic. Very rare. Okay, please remember this. Clinical feature present at birth with edema caused by massive proteinuria, poor growth, child won't grow, nutrition status will be less. Here also you're going to get hypoalbuminemia, hyperlipidemia, hypoalbuminemia also. Here same thing what we'll get in. They are such children who very frequent, they come to us. Such children hypothyroidism will be there. So because their urinary loss of thyroxine will be there in the globulin. That's what thyroid has to be followed up very strictly, and they should do supplementation such children. So most of progressive renal insufficiency, finally the prenatal diagnosis by increasing level of maternal alpha fetoprotein in the amniotic fluid can be done. Treatment, primary congenital nephrotic syndrome, definitely treatment, renal transplantation has to be done. We can use ACE inhibitors to reduce the proteinuria and hypertension also. Albumin diuretic infusion can be done. High protein diet should be advised for children. Treat the cause of secondary nephrotic syndrome. Please remember this. This will you will get a shortcut. Final conclusion: nephrotic syndrome is a commonest glomerular disease in the children. Please note in your brain. It has chronic clinical course, means more than 2 months, sometimes 1.5 years also. In the cases of steroid dependent nephrotic syndromes, such cases goes for 2 years, 3 years also. Please counsel the parents properly. So with recurrent episodes, relapses are very much common. Okay, so please you should be prepared and you should be keeping in mind. A response to steroid therapy has good prognosis. So 80% of them they'll show good response to steroid therapy. If they respond well to steroid, the prognosis will be good. Close follow-up of the child and the monitoring for the side effects of the immunosuppressants is important. So these are exam questions. Usually I have just guessed and given. Please use to concentrate. Usually the question will be asked as the main question for 10 marks. Describe clinical features and management of child with the first episode nephrotic syndrome. How we are going to approach. We can ask even etiopathogenesis. We can ask clinical features. We can ask management also. So this comes for 10 marks. Okay. Sometimes we'll ask define steroid dependence or resistance. Enumerate. This question will be there. We'll have congenital nephrotic syndrome question will be there. Complications of nephrotic syndrome can be asked. So these are 4 questions. And nephrotic syndrome also. These are 4 questions. Please, you should keep your mind. Further, we can ask short notes on steroid toxicities. And that's what Cushing had already explained. Infections in the nephrotic syndromes can be asked questions as short notes. Urine protein estimation, how you are going to do urine protein estimation? I already discussed about 3 types, 3 things in the urine estimations. Okay. Differences between nephritis and nephrotic syndrome will be asked as a short notes. So this finishes my class. Thank you. And please remember, these are the exam questions. Please note down and go ahead with this. Bobo? Okay. So that finishes my topic and excellent thing. Thank you. It's 156. Yeah. ರೆಕಾರ್ಡಿಂಗ್ ಕೇಳಿಸಲ್ಲ ಅವ್ರಿಗೀಗ ಹೇಳ್ಬಿಡ್ತೇನೆ. Okay, thank you very much. I hope you understood well. Please keep safe and wear mask, keep distance, and mask should be covered the mouth and as well as the nose. Not only the mouth. Please take care. Please don't wander outside. And you have got good opportunity to read at home. And as your parents says, please take care of yourself. Okay, and distance should be there. And you can keep always hand washing. Thank you very much. Bye bye. Take care. always reopen will be announced to you. Don't worry for that. Try and being please keep in the safely and take care of yourself. Thank you.